All right. Thank you so much. Thank you to all the panelists for really a very interesting range of presentations. While people are kind of making their way up to the microphones, hopefully, to ask questions of our great speakers here, maybe I will just start. I mean, so I think we've heard a range of perspectives. And I think it was really interesting, Preeti, to hear your example, particularly after Katrina, your very inspiring account. But at the same time, as I listened to the account of the things that you guys have had to go through at MGH, I wonder how someone at Denver Health will ever be able to establish, a system in which genomic tests could be routinely, equitably offered in the way that you have managed to succeed at MGH. So could you comment on that, and then also maybe reflect a little on this example that Preeti just gave us, of maybe some design. This is for all the panelists. Some design that would allow us to not have to do so very much to ensure equity in the genomic medicine space.
Well, so I'd be delighted to comment. I guess kind of off the top of my head, I could probably say two things. First of all, is I don't want to give anybody the impression that we've succeeded. Let's just start with that. I would also say, from my perspective, you can never, ever take your eye off the ball of equity. So I'll tell you, we also have a number of community health centers. We take care of populations in very, very diverse and I would say dynamic populations. And so just back to that interpreter issue, we discovered that we would hire people speaking a certain language. And then when the Central American crises happened or other things happened, that languages spoken in the communities completely changed. So you can never, ever say you're done. I guess I just want to be 100% clear about that. So I think for us to, Malia, maybe this is the point I was trying to make at the end. I think if we need to recognize, and federally qualified health centers are a special breed. We also work with a lot of those, but the forces that drive those are going to be largely Medicaid policy. And so I think we need to be at the table for figuring out how to influence Medicaid policy and working with Medicaid policy. Luckily, I will say the people who set Medicaid policy, I can't remember who showed, did you show, Sean, that picture? The graph, I think, from Massachusetts is such a telling graph. I mean, that amount of money that we've gone up of what we're spending in Medicaid every year and gone down in every other, library, police, you name it. We're just moving that money to Medicaid. Mm-hmm. And the problem is that if you look at what we're spending on it in Medicaid, maybe it's like a lot of what you're saying, we're not necessarily spending it on things that are particularly forward-looking. And so I would argue that there is a way to bring these things together, and it has to do with the creation of Medicaid ACOs, and that Medicaid ACOs need to be really working with different partners, including this community, to really take this on. And we need to hold ourselves accountable to controlling costs in other areas if we're going to add this in. I will just, and addiction's a big one of them, so I'm all in.
I can, a couple things that I think are particularly important in a lot of different spaces, but if we're talking about access to care, the one thing that can really help provide equity or access is, the system is so complex, but having a support system to help navigate the system, so a navigator, navigation, care management, or care coordinator can really help support additional needs for services, including understanding what genomic medicine or precision medicine is all about. It can help facilitate all the different types of insurance policies, and not only from a patient perspective, but from a provider perspective. We often have some very high no-show rates in different types of care. I don't think it's that we don't have enough resources available. Quite honestly, everybody's always asking for more resources, but we spend more money in this country on medical care than anyone else in the world, and we have the best doctors in the world. We have more research than anybody else in the world, and we have more technology and resources than anyone. I actually think it's more about how we think about care, rather than waiting till everyone is in crisis. treating a suicide attempt after it happens rather than working upstream to help coordinate care to prevent the thing from ever happening. All of that extra high intensity intervention that takes so much extra time and cost at the back end can be prevented upstream by preventing low intensity intervention ahead of time with better coordination of care. And you can see how the structure, even within the context of the resources we already have, can be reframed to focus in a better way.
Okay, all right. Question over here on this side.
Yeah, I'm David Litwack from the, excuse me, from the FDA. One of the things I've heard in many discussions of precision medicine relating to payment is the idea that coverage with evidence development would be the, it's usually a solution to every possible problem that's thrown out. And then I hear payers push back and say that's not possible. And particularly for Sean, I'm wondering if you can expand a little bit on how CED can or can't be used.
So I'm kind of still a fan of CED. For those who don't know, coverage with evidence development is just where payers pay for certain technologies and services where the evidence is not definitive or considered adequate, but it's paid for in the context of additional research. And I think particularly for diagnostic test precision medicine, I think there's a lot of it makes a lot of sense, in part because I think it's just very hard to get to the level of evidence of, definitive evidence of improved health outcomes, which is what payers look for, in a sort of an efficient and affordable way without having some insurance coverage. So it makes logical sense. Sort of where it runs into trouble is it's not easy to do the additional studies, that those post-coverage studies are difficult to achieve, particularly if you're aiming for a high level of rigor. So if you're using, registries and other kind of non-experimental designs to try to show improved outcomes for a diagnostic test, it's challenging. And then, even once you have the let's say you're successful and you have the better evidence and you're more persuaded. You've kind of added a new tool with better evidence that of clinical utility. People should probably be using it, but then I think there's all these inefficiencies in just how resources are deployed generally that I'm no longer. I think I used to be a believer that better evidence solved the problems of the healthcare system. I'm probably stupid ever to have believed that, but it's helpful, but obviously insufficient.
Okay, we'll take a question over here.
Yes, thanks, Malia. Thank you all. This was very, very revelatory. I'm Rita Sharon. I'm at Columbia, and I chair the new department in medical humanities and ethics. And I've been running our narrative medicine program for a while. I'm impressed with how many times the concept of language came up today, and how we have to be very careful about how we talk about things, and how not only we talk about them, but we think about them and understand them ourselves. It may be, that one of the things we can learn from the palliative care doctors is how to lengthen the time of a visit that is devoted to genomic counseling or genomic risk and information generating. They were able to do it, and maybe some of the others can too. But the more important thing I want to mention is what Dr. Armstrong talked about in the implicit bias of physicians toward groups of persons who do and don't need genetic testing or genomic testing. These are very deep language-based, deep belief structures. We're doing a small study at Columbia now looking at how physicians talk about weight. We're studying weight bias and how different physicians think about care toward persons with obesity And it's very, very, it's very marked by their actual beliefs about deep issues of behavior. And we're trying to move the needle on that using narrative methods of really helping clinicians discover what it is that their implied biases are about and arise from. So there may be lots of work to be done, not only in improving the so-called communication skills of clinicians, which has its limits, but in really deepening their capacity to understand what it is they are thinking and feeling and behaving toward patients who end up being biased against in receiving their services.
I'll just say that I couldn't agree more, and I think what you're working on sounds really so unbelievably important. I will just say that I think that same discussion, and I thought it was so amazing to hear in the patients and the panel that we had first, that, you know, often what I find myself doing is starting that, I'm a primary care doc, starting that same discussion within families so that they can figure out how to go back and talk about what's been going on in their family. I mean, genetic testing can bring out all sorts, I mean, for those of you who practice that, like there's nothing quite as dramatic as discussions that can happen around genetics. And so I think that those types of conversations need to not just be in the exam room about how we do this, but also I think across the spectrum.
Okay, please, on this side now.
Thank you. I'm Turkan Gardiner, applied statistician. As I was hearing Dr. Armstrong speak, I could not help but remind myself of terminology. Terminology meaning what exists out there versus discrimination about what the provider does in what he sees as a patient. For a number of years, I worked with data from the Atlas of United States Mortality, compiled by the National Center for Health Statistics and later by NCI. And for many years, they couldn't combine the data for the two race groups and for the two gender groups. So when maps were being prepared, there were 4 maps, because for each county and for each state or standard metropolitan statistical area, the means differed significantly. The variances differed significantly, so they could not provide one map for each cause of death, much of which were types of cancer. Now that's what exists in terms of personalized medicine, which is also referred to as precision medicine. Now, some of the deaths, of course, you didn't know what started and what ended up as death. But we should really distinguish between what has existed in these communities for many years versus what we're doing in terms of giving access to health care. What do you think?
Well, I think you raise a number of really important points, and I spent a long time in my early career just trying to think about how to link data in the way that we measure it in any different ways, and it's one of the efforts that I think a group, you know, different communities could come together around, and there's been huge progress on that. I don't want to sound like there hasn't. I think there were a lot of great comments by Dr. Bradley about the current challenges and how we think about racial and ethnic categorization and how that relates to ancestry as well as social forces, and so I won't get into that in any way. I think for on the ground, you know, I personally believe that we just, there's a dynamic issue. Genomics is moving so quickly as we think about what we learn about genetics. I didn't have time to show those slides, but how when we start out in a different group or in a different question, we have a tremendous amount of uncertainty. And often that uncertainty is particularly great for people who are, let's say, not in the largest ancestral group in that study or have different types of outcomes. And so we don't have a good way right now to get the community to catch up, I think, of the practitioners when we actually start to answer those questions. So we've done studies, as you probably all are aware, the rates of BRCA mutations are actually quite high with with our current technologies amongst African American women. But if you go out and you survey most providers, they're still back kind of 10 years, and they still think that the variance of unknown significance. So we've got to match our changing data. Maybe it's coverage evidence with something to what their community is. And I don't have a simple answer for that. I just want to be 100% clear. I haven't solved anything.
Okay, thank you for that. A question on this side.
Thank you. Sue Friedman from Force. And I had a question for Dr. Tunis. So you talked about value-based payment and that, if the evidence is there, then, then the chance of it getting covered is more. And probably because I don't understand a lot about Medicare and CMS and how they make these decisions. But there's a lot of evidence about, for example, coverage or outcomes with BRCA testing or Lynch testing in people who haven't had cancer, and yet Medicare is not allowed to cover those preventive services. And then when you look at like screening on the colon side, you have risk-based screening, coverage for CMS, but on the breast cancer side, you don't. And so I'm just wondering, are those really evidence differences, or what does it take to make that more equitable?
So there's kind of a lot of like policy history related to Medicare and screening versus diagnostic services, and I don't pretend to know all of it, but at least at a high level, prior to the Affordable Care Act, there wasn't. Screening was essentially not a benefit within the Medicare program. So the only way breast cancer screening or colorectal screening were paid for by Medicare was because separate legislation was passed for each of those. It wasn't built into the baseline benefit scope for the Medicare program. So in the Affordable Care Act, that was when, as I think Dr. Brawley mentioned, the link was made that, for A and B recommendations, those could be covered by Medicare and obligated on private payers as well. So, but those coverages are, limited to what the actual recommendations of the U.S. Preventive Services Task Force are. So the preventive services that were, the subject of prior specific legislation could have some of the, the risk-based screening, because that was built into, the legislation and the following regulations. The stuff that is now covered under the the Affordable Care Act is sort of limited to what the Preventive Services Task Force recommendations are.
But my understanding, unless I'm missing something, and I wonder if some recommendation can come out of this, for example, that Medicare will not pay for BRCA testing in someone who hasn't had cancer, despite the USPSTF guidelines. So I guess I find that confusing, but I don't know if there's anything that could kind of bring everything in alignment, or maybe I'm missing something. So, oh, good.
Bruce Quinn, Medicare could make a benefit for women who don't have breast cancer yet, but they haven't chosen to do so yet through the NCD process, National Coverage Process. And I was part of a group that brought it to Medicare a year and a half ago, asking them to make the benefit you're asking for, and Medicare declined to do it at that time because U.S. Public Services is in the midst of a 2-year reevaluation of its breast cancer recommendation. So people have asked Medicare to do it, and they're literally waiting on the next iteration of the task force. But it's come up over the last couple of years.
Thank you.
Alice, I think you were next. Yeah,
Thanks, Malia. Alice Popejoy from Stanford University. Really appreciate the organizers and the panelists for this incredible talk. It was really illuminating for me to learn about the payer and the provider perspective. I have two questions going to take advantage of the breadth of your topics that you covered. The first is about mechanisms for interacting between those of us who are working in public health genomics and the payers and providers. Like, what are those mechanisms and channels of communication that we can tap into? And secondly, I wanted to ask about mental health prevention and services for providers. If we really internalize this notion that healthy employees are effective employees, I think most of you in the healthcare systems know there's an epidemic of suicide and mental health issues among medical providers. And with a lot of friends in residency right now, I know there's just a lot of this going on, but that if they, at least in emergency medicine, I know from a friend that if they ever indicate on a survey that they have depression or any sort of mental health symptoms or that they've sought services, they won't be allowed to practice anymore. So how are we going to expect providers to take on a whole new wave of precision medicine if there is no mental health services for, and this could just be particular to one hospital or one department, but I'd be curious to know from the panel what your perspectives are and how we plan to address this.
Well, so on the second issue, I can say, absolutely, that's a problem. I mean, it's pretty easy to say that, but I mean, I think, here's the thing. So providers, and this is true that in a lot of areas, people are, it is either a rule that if you come forward with a mental health issue or suicide risk issue that you can't practice anymore, or it is it's an internalized belief system that that's what is going to happen, that you'll be looked down upon and treated differently. So physicians and health providers, and specifically mental health providers too, have significantly high rates of suicide and mental health conditions, and yet they're not very good at being able to get care, and not just themselves, but even it's a value system about looking at each other. So I think some of this is a conversation that we need to have as a society and as a culture of care, of how, are we going to support caring about mental health conditions the same way we do as medical conditions? There's a long history of treating those things differently. And it's the same way in the language that we use. We say somebody committed suicide like they committed a crime, rather than saying, I mean, who would say you committed cancer, or you committed a heart disease? I mean, you would never use that language. But it's sort of an institutionalized belief that it's a choice to have a mental health condition, or to whether or not you have a decision to get better from that mental health condition. Like, just start feeling better, stop feeling down. But it's not that way. And I think part of this is recognizing in the medical community and that we need to treat that differently. That we should treat that the same way we do every other medical condition. So that, it's a different story, but it's certainly people who are impacted by those conditions treat their patients differently too. Because they put that. In fact, some people who have those conditions are even more stigmatizing towards their patients that have those conditions, not by purpose, but by sort of default.
Maybe could I just add, I'd probably give you two concrete suggestions about each of those. So on this one, I actually think most people were not aware that there is state variation and what happens when you report something on your license. And actually, we have a group, and actually there was a piece in the New England Journal just last week about the power of organizing and activism to address burnout. We have a group in Massachusetts trying to take that on. If you want to email me, I'm happy to connect you. I think your generation should change it. It's ridiculous. It just will get changed, and I think you should change it. It is absolutely ridiculous. On the first thing, I guess I would look to my neighbor to my left, and I would say the easiest payer and employer for you to find is your own payer and employer, And I think the more that, as you probably know, there's huge business in your insurance. So it's amazing at Partners Healthcare what we do. We are self-insured. I'm sure you are self-insured. And so learning how to influence the policy there about what's covered and how to do it, I think can be a great start. And then back to Sean's point, we can create these kind of examples and experiments that then we can take to national coverage. I don't think we're going to start with national coverage. I would start, we can do that for BRCA, I'm all in. But for other things, I would try to start locally, work with your local payers and your providers to do things, and I think you'll get a crazy long way.
I can just add a couple comments. I'm actually probably better equipped to answer the second question, but we can talk at the break about that. I would just reiterate Katrina's comments, and you have some sort of committee at Stanford, Medical Benefits Advisory Committee. I'm sure if you contacted whoever is on that committee, whoever chairs it, they would be delighted that someone has an interest. And
tell them how much you like your benefits.
Because it's hard to get good people on. Usually they meet in the evenings and things because people are busy. But I think you can learn a lot. And from my standpoint, I think if you can chew off a little bit, for our IVF program, we did cover the counseling, we covered the diagnostics, we covered the medications through our prescription drug plan, but we didn't cover the actual assisted reproductive technology. And it was someone coming to the table and saying, you know what, this isn't fair and this isn't equitable. And, a university that says, we want to be equitable. And it led to a whole change. And I think that whenever that paper comes out from Jim Dupree, it will be of interest to a lot of people.
Okay, Laura, you can have the last question for this session.
Thank you. So I'm Laura Rodriguez from the National Human Genome Research Institute. And again, thank you to the panel for a really great series of presentations. And I think my question really maybe connects this panel with the one just before lunch a bit. And I had a question for Dr. Armstrong. You talked a lot about what you were doing to try and build genomics into the system and manage the important questions about the care and the flow of care. But I was actually curious as to, as much as everyone in this room believes in it, what were the arguments that convinced the health system to invest in the infrastructure to do this and make this change?
Well, I would have to say these are ongoing discussions. I mean, whoever in the, I think we were talking about making a budget, right? I just want to be clear. Like every year you're trying. And so I will tell you, I spent, maybe I shouldn't admit this in whatever taping this is in, I spent most of Tuesday afternoon trying to figure out how to reduce my TAVR budget, which is transaortic valve replacements, to be able to support my genetic counselors, okay? And it's like real life. This is how it works. Like it's just like a household budget. Like if you want to go to France, then you can't also, buy the new car. So it is the health system executives, and I guess I would just say, I just think they're people like us, right? And they're just trying to figure out how to make the right trade-offs. And so I would have to say that, and that's probably why I'm so trying to get you guys focused on this supply cost thing and that other report. I think we have to make space in our healthcare budget for these services. And I think we should stand up as providers both to make that space, if that makes sense. And I think the points that you showed about, emergency room visits and other things, we discovered the same thing in our employee population, and this is like embarrassing to say, but a lot of the reason that our lowest paid employees were going to the emergency room instead of primary care is that our policies didn't let them leave their job during the day to go to their primary care provider. Like, no, go back and ask your own employers. It's amazing. If you are a cafeteria worker, it turns out that you don't, if you're sick, you have so I guess I would say that it's not a done deal. Like, I think the arguments that we make, right, are that prevention and investment in precision medicine is the future, and that we need to get ahead of the curve in doing that. The only other thing I will say, and all of you guys know this who live in health systems, is that most people who run health systems are crazy competitive. So if you tell them that like Vandy's doing it or Stanford is beating us and Stanford's now ranked #1 for colleges and that's all because Harvard didn't get some genetic counselors, they're like, man, we need more genetic counselors. So I use that all the time. And I've heard, that Northwestern is about to do this. And so they're all like,
Thank you.
All right, and on that note of hyper competition, please join me in thanking our wonderful panelists.